Okay, so good morning, everybody, and welcome back to the final journal club before the summer break. Really delighted to see all of you joining us. It gives me great pleasure to welcome Matteo Lunardi, who will be presenting this very interesting paper looking at bifurcation lesions and long-term mortality. And as our expert, a warm welcome back to Michele Pighi. Thank you again for joining us. So, Matteo, over to you.
Thank you very much, Ari, for your kind invitation to this journal club. So that's my pleasure today to present this interesting paper, Impact of Bifurcation Lesion on 10-year Mortality in the syntax trial, for which I have collaborated with the great team of Professor Rice in Galway. What do we know about bifurcation PCI? For sure, we know that they led to higher rates of other events, at least up to more or less 5 years of follow-up, but we don't know if at very long follow-up beyond 5 years, which is the outcome of this patient, in particular if an alternative strategy like the surgery is better or not. So our aim was to evaluate indeed the impact of bifurcation lesions in the syntax trial population at 10-year follow-up. That was evaluated by the extended survival study of the syntax trial, the syntaxes, assessing only the vital status of this patient at 10 years. As you know, the syntax trial included 1,800 patients that were patients presenting a complex coronary artery disease, that means or three-vessel disease or left main disease, that were equally randomized to receive either PCI or CABG. And of these, as you can see, the majority presented at least a bifurcation lesion that included both the bifurcation of the left main or other coronaries. We divided the patients, these patients that were a total of 1,300 in 4 groups. Patients treated with the PCI that presented at least a bifurcation, patients treated with PCI without bifurcation, and the same groups in the CABG arm. Among the baseline characteristics, we can say that patients with bifurcation were actually younger, were more frequently male, had a higher ERO score, and in particular, as expected, had a higher anatomical syntax score. One of the first results of the study was that the PCI of the bifurcation lesions led to a higher occurrence of repeat revascularization at 5 years. And this was significant when compared to the same patients, the ones treated with PCI that didn't have any bifurcation to treat. While in the CABG group, as you can see, the difference between these two subgroups, bifurcation, not bifurcation, didn't exist. On the contrary, the major adverse composite event, death, stroke, or cardiovascular event, death, stroke, or MI at 5 years, didn't differ in these subgroups, although there was a tendency always in the bifurcation subgroup of the PCI-treated patients of a higher occurrence of MACE at 5 years. But let me show you the primary endpoint of this study that was the very impressive one. The all-cause death at 10 years basically diverged a lot for the PCI patient having a bifurcation. As you can see, they died, the death rate was about 30% in this group compared to patients that didn't have a bifurcation and were treated with PCI that had a mortality of 20%. And this difference was, of course, significant with an adjusted hazard ratio of 1.6. While in the CABG group, the two curves were totally overlapped, meaning that the CABG didn't impact anyhow the mortality at 10 years if we have a bifurcation, just because the bypass circumnavigates the complexity of the bifurcation anatomy, having better results at 10 years. So We furthermore analyzed the subgroup of patients underwent to PCI for a bifurcation to understand if there was any reason leading to this higher mortality. And we analyzed in particular the stent technique of these patients, comparing the patients receiving 1 versus 2 stent. And as you can see, the patient that received 1 stent were the majority, about 70% of them. And these are the Kaplan-Meier curves of the 2 subgroups according to the stent technique. As you can see, the 2 curves diverge again at 10 years. The patient receiving at least, the patient receiving a 2 stent technique died more at 10 years than the patient that received only 1 stent. And in particular, these 2 curves diverged at not at 5 years, but beyond 5 years. As you can see from the landmark analysis, we have a small difference up to 5 years, but it was not significant. And this became significant beyond the 5 years, up to 10 years, something new in this field. So we can summarize these first results saying that, okay, we know that bifurcation, if treated with PCI, led to higher risk of repeat revascularization. We already knew that. We didn't know that at 10 years of follow-up, PCI of a bifurcation in the context of a complex coronary artery disease led to a higher mortality compared to patients without bifurcation, whereas the CABG didn't lead to these death rates. And the 2 stent technique compared to 1 stent technique actually led to worse result, always at very long follow-up. So shall we say that if we meet patients with a complex coronary artery disease, like the ones enrolled in the syntax trial, we shouldn't refer the patient to percutaneous treatment, but just refer him to the surgery? We didn't actually believe too much to this finding, because also in the paper, it's not reported in these slides, but we observed that some patients, and in particular the ones with left main bifurcation, actually they did well at 10 years of follow-up, also with PCI, and their outcome was basically the same of the ones treated with CABG. So we wondered if there was something that we were missing about the analysis. So that I have to introduce the concept of the average treatment effect. These results that I have just shown basically represent the overall population of the study, the 1,800 patients enrolled in the trial, but they do not represent the individual risk of a patient to die at 10 years. And this depends on the characteristics of the patients beyond the presence of a bifurcation. And nowadays, more and more is important to individualize the therapy, the treatment, and also the risk evaluation of a patient before the treatment. So what did we do? We analyzed the SINTA score 2020, that is the last version of the SINTA score, in every patient of this trial, in every patient presenting a bifurcation, so the population composed by the 1,300 patients. And as you can see from this complex graph, we reported all the risks calculated from the syntax 2020 with these dots. Basically, every dot represents the risk of a patient to die at 10 years after either PCI or CABG, blue for PCI and red for CABG. And it was demonstrated that if the difference between the risk of dying at 10 years, as calculated by the syntax score 2020, after PCI minus the risk of dying after CABG is less than 4.5%, we have equipoise for PCI than CABG, or a preference for PCI. While if this difference is more than 4.5, well, the outcomes are much more better. are much better with CABG than PCI, so CABG should be preferred. So we have ordered all these patients in a new order in this graph according to this difference risk, to this risk of difference of the risk. Basically, the first patient, patient number 0, is the patient that has zero difference between the risk of dying after PCI or after CABG, and the patient number 1300 as the major risk, the greatest risk, the greatest difference of risk between PCI and CABG. So that we have the patient on the right of the screen that had a difference risk higher than 4.5%, where the CABG was preferred. Let's do an example just to explain better. We have this case, for example, with many comorbidities that had a calculated syntax score 2020 for mortality at 10 years of 57.8% after PCI and 40.8% after CABG, so that the difference of his risk is 17%. And in this case is higher than 4.5, so that CABG is preferred. On the contrary, on the left of the screen, as you can see, we have patients where the lines are overlapped, the blue and the red lines that summarize all the patient's risk are overlapped. That means that the PCI and CABG are equiparable. Indeed, the difference of their risk are less than 4.5%. Let's do another example. We take this patient that, for example, has fewer comorbidities than the previous one. And in this case, his risk of dying after PCI is just 10.5%, and his risk of dying after CABG is just 8.3%, so that the difference in his risk is 2.1, that is less than 4.5%. In this case, PCI and CABG are comparable, and the patient can be referred to either. Having said that, if we look at this graph, we see that up to 16.5% of the patients had a difference in the risk minus than 0. That means that PCI was better. And up to 48% of the patient of the overall population had a difference in the risk less than 4.5%, meaning that they could have been referred to both treatment without difference in their risk of mortality at 10 years. And to confirm this, we have calculated also the observed mortality of this patient that is represented by the dotted lines. And you can see how they are overlapped to the continuous lines, meaning that the predicted mortality that we have calculated is absolutely reliable, as it is the syntax score 2020 as predictive score to use as a risk assessment. So the very conclusion are that yes, there is a average treatment effect that says us that PCI in bifurcation tends to do worse than CABG at very long follow-up at 10 years, something that we didn't have so far in the literature. And this is only the average treatment effect. This is only the overall picture of the whole trial. But we have to mitigate this message looking at the individualized risk of a patient, because in the overall population, up to half of the patients could have been referred to either procedure without difference of the 10 years mortality according to their treatment. Thank you very much.
Wow, Matteo, thank you. That was a fantastic presentation and a summary. I've definitely woken up now. Really nicely summarized, quite a complex paper and topic. So we'll invite shortly Michele Pighi to give us his expert insight into this paper, the field and bifurcations. For anybody, if there are any questions, please either type them in the chat and we will answer them, or you can ask them live from the experts or from Matteo, who did a fantastic work with this project. So questions were open and interactive, but Michele, over to you, please.
So thank you very much, Ari. First of all, thank you, Matteo. Great presentation on a very provocative and I would say, complex topic and paper actually. So the first thing I would like to raise, taking up from the conclusion of Mattia, is do we think that should we avoid bifurcation treated by PCI in all the 3-vessel left main CAD patients? So at the first glimpse, this paper suggests yes, we should just avoid it because CABG is better. But actually, to me, if we look a little bit for an in-depth analysis of this paper, the answer is no. As Mattia suggested, actually, we have been looking at average treatment effect. Okay, so we have to move a little bit from there to get a concept of personalized treatment, because in the end, what we have in front of us is one patient. Our patient is not the average patient. And so I would like to stress the importance to adopt in our clinical practice those new scores that those teams have built, because those really have the ability to discriminate in our single patient that we have in the cath lab, and in particular before we bring them to the cath lab, to decide which is the right strategies for them. So this is something is key. For example, in my practice, I've seen some difficulties so far in update myself with those syntax. I used to the anatomical syntax score, but for example, also studying this paper, syntax score 2020 looks to me very helpful, because doesn't move just from looking at the angio, but looks really at the patient and his characteristics. That's the first thing. The big picture that Mattia showed you was based on the absolute risk difference. Okay, so this team shows us that if we look for a zero, okay, absolute risk difference, only a small piece of the cake is for PCI, because you see it will be between 15 and 20%, so a very small portion of the population. But the team before studied through the Credo Kyoto analysis that probably we have to move a little bit more further and accept an absolute risk difference around 5%. And this allows to categorize our population at least in two, where there is an incubus in the lower part for PCI and CABG, while you can identify those patients which are more complex following the syntax 2020 and will be armed by PCI instead of CABG. It's sure that bifurcation is a very complex topic for interventional cardiologists. It's clear that bypass just bypasses the problem, while cardiologists have to fix it. And so it comes into analysis, how complex is the bifurcation, something that for surgery is not a problem at all. Okay. And the other aspect that we have to analyze is the same for 3-vessel complex disease and left main CAD. Actually, this paper says no. There is a clear difference in patients with 3-vessel complex disease with bifurcation, which shows higher rates of death, stroke, MI, in particular after the 5-year follow-up up to 10 years. While for left main CAD, this difference is not. And that's something in line with some recent also findings. For example, there was a meta-analysis, a recent meta-analysis by Sabatini, who was looking at the syntax, pre-combat, Nobel, and Excel. And they found that for left main CAD, in patients with low to intermediate complexity, there were no difference actually between PCI and CABG. So we have to differentiate a bit from these two settings. Another key message that I found in this paper is the key role of the heart team. So we are used to this concept of our team, particularly for structural, right? So every TAVI patient has to be discussed, and it's much less in the coronary field. But particularly for complex 3-vessel left main CAD, that should be the way to go. So this kind of patient has to be really discussed and weigh the risk and the benefits between PCI and CABG. So that to summarize the first part, which was really about the individualized treatment. Another key aspect that I would like to suggest, if there are no other questions, is the two-stent technique.
If I can interrupt you,
yeah, sure.
I think it's important also to underline that we are talking about basically an old study. So we are talking about old technologies, and these 10-year outcomes may be better now. Of course, it's an intrinsic limitation of the study. We can't have we couldn't have a so long follow-up with new technologies, but all these results that are presented should be seen in an optimistic way, because we expect a better result with the new techniques, new devices, and just a final comment.
That definitely a great point, Mattia. This is a key message, because for sure, and we will discuss with you after, because I have a provocatory question for you, is that we see a study that is a 10 years long follow-up. So we are looking at platforms and techniques that are 10 years old. So that's a key message. And taking up from this interesting side from Mattia, I would also stress that, so there is something that is striking. 1 versus 2 stent techniques for PCI in bifurcation. It's impressive, the message of this paper. It seems really that 2 stent technique is worse for patients, and in particular, this is something that goes a little bit away from what we have seen so far. I mean, the latest, biggest trial that we look at, like ABC Main, DK Crash 5, says that, okay, it seems that the results are the same and both are good for patients. But let's remember, and I would suggest also everyone who is interested to look at the analysis that the PCR Online did last year, just after the publication of the two papers. Those studies have an endpoint at 12 months. Okay, is it 12 months the right endpoint to decide between 2 techniques? That's the big question that we have. The paper by Mattia suggests that probably it's not. I mean, even 5 years, if we look back at the biggest trial, not post-hoc analysis, but pre-planned analysis, the longest follow-up is the DK Crash 2, which was done in 2015. Now I have a 5 years follow-up. So no study have more than 5 years follow-up for bifurcation. This is the first one that provide us with a glimpse of what happens afterwards. And we can clearly see that there is a significant difference between these 2 techniques. Why? Probably because the techniques were less standardized before, because probably, as Mattia suggested, the platform were different, maybe. I don't know, Mattia, do you have any insight from the techniques used in analyzing this paper on your side?
Yeah, of course. I have a slide showing the different techniques used in the syntax trial, but it's not very useful actually. One moment, just it's at the end, of course, one of the not prepared slides. Here we go. So as you can see, 70% of the population, as I said, was underwent provisional stenting with 1 stent, while the others received 2 stent. And you can see quite old stenting technique that nowadays are not anymore used, like the B stenting. The DK Crash is not was not yet existing, but they were very, very variable among the centers of this trial. So it was difficult to perform a sub-analysis of these techniques on the very long-term follow-up that we didn't do. Yes, the technique was not standardized. The protocol didn't mention anything about the bifurcation technique, so we can't make any conclusion about the different stenting strategies, unfortunately.
I believe that.
I am Antonio Colombo from Milano. I'd like to add some comments.
Professor, yeah.
I know this paper quite well because I reviewed the paper several times. I believe there are a lot of limitations. In the message, bifurcations are a marker of more advanced disease, period. If you have more advanced disease, the prognosis is worse. And if you need the two states, is a subgroup with even more advanced disease, which need two states. The other important limitation is that the loss of follow-up of patients is very high, is written in small prints, but especially in the surgical group, you have a lot of patient loss of follow-up. So I don't know what does it mean. Are they dead or they are just around? And the third limitation is that the way we perform a PCI now is very different from the time of the syntax study. We had patients in San Raffaele where we implanted 15 stents in the syntax study. We rarely now implant 15 stents. We didn't use IVUS in complex patients, and the last point, we know how high is the risk of very late and late thrombosis with the taxus stent. So I think to come to the conclusion that having a bifurcation is a way to decide for CABG is a very naive approach. That's my comment.
Thank you very much, Professor.
Thank you.
Great comment and synthesis of the limitation. Taking up from what Professor says, Mattia, I would like to ask you something. So you just led the writing of the BFARC manuscript. Based on what Professor said and what are the comments that we made during this paper, do you have any suggestion based on your experience and what you share with the team that wrote the paper to plan future studies that can take up from what we said today?
Thank you, Michele. Yes, that was an interesting paper, of course. And yes, we considered in the paper that we could have a different type of study about bifurcations, and we can't have the same endpoints for all the study. For example, first-in-man studies can't have the same endpoints, follow-up methods of studies comparing revascularization strategies like this one, like CABG versus PCI. In particular, for this category of studies, surgery versus PCI, we said that clinical endpoints should be set as primary endpoints compared to other categories. That means patients' reported outcomes, patients-oriented composite endpoint. And in particular, we stress that the follow-up should be reported up to 10 years if surgery in particular is included in the study, but is recommended also for non-surgical studies. So I think these are important statements that are proposed by very experts in the field, international experts, and in the future study we should apply these regulations to have a better result in the future, or more standardized at least.
Right, I think good discussions. Thank you, everybody. If anybody has any comments or questions, now would be a good time. We have many people connected and many experts here, so please do feel free to come up with your questions. Perhaps I'll just start with one to you, Mattia. We've got a lot of early career interventionists joining this conversation. Syntax 2020 versus normal syntax. So is this the way to go forward if we have a patient in front of us, and what extra information does it give us?
Sure, if this is a good question, because I discovered that most of the operators, in particular young operators, didn't know about these new versions of the syntax score, and everybody teaches the old syntax score, only the old syntax score. Well, the last version, the syntax score, includes also the very first one, the anatomical syntax score. So there is no reason not to apply it. Basically, the syntax score 2020 starts from the anatomical syntax score that is the same of the first version, that includes all the anatomical issues like the bifurcation, etc. And in the new score, compared to the one that was published a few years ago, that was the syntax score 2, there are a few more clinical variables that were shown to be predictors of 10-year mortality. That are in particular diabetes and smoking, whereas clearance, creatinine clearance, ejection fraction, COPD, the presence of left main disease or three-vessel disease are the same of the syntax 2. And the real difference compared to the previous version is the prediction of the 10 years mortality that was not present in the previous one. The previous one was able only to predict the 4-year mortality after either CABG or PCI. So we have a very useful individual score now that can help the heart team to at least guide the decision. Of course, it's not a mathematical decision, and we always should keep in mind that, as Michele said, we have a patient in front of us. But yeah, it was validated against 3 external populations, so it's a strong analysis, and I think it's a reliable tool.
Okay, thank you. I think that's an important message for the community. Sticking with the young and early career focus, Michele, a question for you. A lot of people are, let's say, will be starting their cath lab journey, or in the first early years of interventional cardiology. Now in 2022 contemporary practice, if you see a bifurcation lesion, what would you say are some golden rules that we should all keep in our minds when, it's not a simple type A, it's bifurcation? How should we be approaching that? What should we be thinking in our minds?
So first of all, the thing is knowledge. So we have, as early interventional, we have to read, to be updated, and to keep it simple as much as you can, and be confident with the technique you learn. I don't see any advantage in knowing thousands of bifurcation techniques. I do believe that you have to be confident when provisional for sure, and then have a couple of two-stent strategy technique that you are confident with, because we have seen that also in the data that Mattia presented, that there were a granularity which is very high in those techniques. We have to adapt, but for example, trying to perform decay crash without any experience or without imaging guidance does not benefit the patient in any way. So you have to learn, as Professor suggested, use imaging as much as you can, in particular if you have difficult bifurcation or if you have left main bifurcation. For sure, for early career, is great to have a mentor close by to ask for tips and tricks in performing those procedures, and always discuss the patient. So even if it's an ad hoc procedure, because the bifurcation looks not so much complex, just look up to your mentor or senior physician, ask for a suggestion. And if it's a patient that you believe is quite complex three-vessel disease, there is no shame in taking the patient out of the cath lab and discuss with the senior or with our team before making a decision. As you see, that's impact not just 1 year, but impact the whole life up to 10 years of this patient.
Okay, thank you. And Prof. Colombo, are you with us? it's on mute. I'm not sure if...
Is there?
I'm here.
No, Prof. I have one question just as we're finishing and approaching the end. You've seen the entire journey of bifurcation PCI, and Matteo showed that nice slide about some of the old techniques which we don't do anymore. So projecting things forward in the next 10 years, where do you see the improvements in bifurcation PCI? Do all the young people connected need to think of new techniques in addition to obviously implementing imaging and physiology? But how do you see two stent or two lesion bifurcation PCI changing over the next 10 years?
First of all, I think the way we discuss bifurcations should be simplified. I was astonished to see a 5 pages paper about endpoints in bifurcations in JACC. I think the approach to bifurcation should be summarized, not summarized, to be described in half a page, no more. 300 words, no more. You don't really need such a elaborated textbook approach when you're dealing to a bifurcation. So this is my first point. One stent, two stents, I think it's a passé approach. We have to, first of all, a big categorization is to know which bifurcation is to keep it open and which bifurcations you have to take the side branch into more consideration. That's the first important decision. If you keep it open, just keep it open and do nothing on the side branch. If you don't take this approach, then nowadays, with the availability of drug-coated balloon as well, especially in Europe, a lot of decisions are taken following pre-dilatation. Because if following pre-dilatation of the main branch and the side branch, if he has disease, you see that you have a good result, the approach becomes more conservative. One stent or even no stents. If after pre-dilatation you see that the result is not as expected, then you change your strategy. So this is not stressed enough, but I believe the approach after pre-dilatation is the one that should guide your strategy. Then culotte, two stents, crash, mini crash, this is a matter of operator preference. But that's it. That's my whole chapter on bifurcation in these words.
Great, thank you so much. So I think we've come up to time. If there's no other burning questions, we can conclude the session here today. So first of all, I'd really like to thank you, Matteo, for joining us. First of all, congratulations for this work that you've been doing. Really impressive, but thank you also for summarizing and presenting a lot of this and sharing some really useful practical tips and tricks. To our expert, Michele Pighi, thank you for joining us again. We really appreciate your input, your insights, and to everybody connected, and especially Prof. Colombo, thank you for joining us and sharing with us some of your thoughts as well. It leaves me just to say this is the final journal club that we'll have before the summer break. So thank you all of you who've been joining us, connecting, sharing, interacting. It's really you, all of you, enrich this journal club experience, and we learn a lot from it. It is early in the morning, but it is very stimulating and a great way to start the Friday and go into the weekend. So thank you to all of you. I would personally like to thank all the team of the Journal Club who've done a fantastic job in bringing these sessions to all of you. And yeah, have a wonderful summer, a great break, and we'll be back with an even bigger, better, and hopefully more interesting Journal Club for all of you to enjoy. So happy holidays from all of us here at Journal Club, and thank you.
Bye-bye. Thank you very much.
Thank you. Bye, everyone.
Ciao.